Go ahead, ma'am.
Hello everyone, welcome to the Facebook live session. I'm Dr. Rajeshwari, Fertility Specialist and Clinical Head, Oasis Fertility, Banashankari, Bengaluru. Today we will be talking on the topic that is infertility and its management, mainly concentrating on the IVF part. Now we are seeing there is increase in the or rise in the fertility issue among the couples. One out of every six couple are facing this fertility issue. What is the reason? The reason can be the cause can be problem can be in the male or in the female. 40% of the couple male has the problem, and another 40% of the couple the problem may be in the female, and another 20% the problem is not seen. We grossly see whether the uterus is all right, ovary is having adequate number of eggs, and the sperm, that is the semen parameter, is normal. And this is all we see. The problem can be at the microscopic level. For this, we call it as unexplained infertility. Now, let's see what is infertility. When do the couple have to go and see the fertility specialist? Infertility itself is defined as when the couple are trying for pregnancy for more than 12 months unprotected, that is, without using any contraceptive measures, and they are having regular intercourse. That's when we say, yes, the couple may be having fertility issue and they need to see the fertility specialist for evaluation. Now, the causes in female, where all the causes can be. One, it can be the ovary. Ovary can be having less reserve, that is low ovarian reserve, or they can have PCO, that is polycystic, that they can be having too many eggs. And because of the hormone imbalance, they may not be ovulating at all. Or they can be endometriosis. So they can be, that is the blood-filled cyst, which can have implications on the quality of the egg, pregnancy itself, because there can be additions and the normal tubo-ovarian anatomy can be distorted because the tube can be pulled away one side and the ovary can be pulled another side. So even if the egg is releasing, the tube is not able to pick up that egg and have pregnancy. Another thing is the tubal cause, where the tube can be blocked. It can be anatomically blocked during development itself, or because of infection, it could have been blocked. And because of infection, there can be hydrosalpinx as well. That is the fluid which is produced by because of the infection that can have effect on the pregnancy itself. Another thing, the problem can be in the uterus. Uterus, there can be a septum or the polyp, which or the fibroid, which can have effect on the pregnancy itself. Because of the certain changes which take place because of the polyp or the fibroid or the septum, the pregnancy may not be able to stick and grow in the uterus. That is the embryo, I mean to say. Then hormone imbalance. Hormone imbalance can be because of the polycystic ovaries. There can be insulin resistance, and male hormone, that is the testosterone, can be high, which can have a effect on the development of the eggs and pregnancy. The other thing can be because of imbalance in the thyroid or prolactin hormone, which can have effect on the development of the egg, release of the egg, formation of the embryo, and pregnancy. Then it could be infection. Infection could be tuberculosis, chlamydia, gonorrhea. Tuberculosis can affect mainly the tubes. It can affect even the endometrium. It can destroy the endometrium. Tubes can be destroyed and it can be blocked. It can give rise to, even if there's pregnancy, it can give rise to ectopic pregnancy as well. And it can have effect on the ovary as well. So the quantity and the quality of the eggs will be affected. Coming to immunological. Immunological body can be sensing the embryo as a foreign body and it may be producing antibodies against the embryo. So auto antibodies can be produced. Or they can be because of any cancer, patient may have taken chemotherapy or radiotherapy, which can destroy the eggs and the endometrium. Coming to the male, there can be problems in the semen parameter. Semen, we see for the sperm count, whether there is adequate number of sperm, whether they are motile, whether they are adequately motile, they have the capacity to pierce the eggshell and go into the egg and fertilize. And the morphology, like we see for the eyes, nose, mouth, even the sperm has a head, cap, neck, and the tail. So whether that is normal, whether all these are within the normal parameters, or there could be some surgery they could have undergone, hernia repair, where that can cause problems for the sperm or the semen to come out. And then can be infection, like childhood infection like mumps, which can have effect on the testis itself. So the testis development have not must have not happened, so there may be no production of the sperm itself. Even the male can have chemotherapy, radiotherapy for any kind of cancer. It could be testicular cancer also. So these chemotherapy drugs, certain chemotherapy drugs, can have effect on the development of these gametes like the egg or the sperm. Some of them can permanently destroy. So any of these can have effect on the sperm production. And coming to the lifestyle, like smoking, alcohol, the smoking can have effect on the sperm production. There can be breakage in the DNA of the sperm. There are DNA in the sperm is tightly packed in the head. There can be breakage in these bonds. So we call that as DNA fragmentation. The high DNA fragmentation index can have effect on the embryo formation. Recurrent pregnancy losses can be there. That is, the miscarriages can happen. And even the varicose, when there is higher grade because of the heat in the testis, they also can have effect on the sperm production and the quality as well, motility. Then when do these couple who are having difficulty to conceive see the doctor or the fertility specialist? For a couple, young couple, if they have tried without any intercourse, without any contraceptive measure regularly, and they are aware of their ovulation time, during that time they have regularly tried for 1 year, that is 12 cycles, then they need to go and see the fertility specialist. So if there are couples young or more than 35 years, if they have been trying, and they young couples who know there is a problem like endometriosis, or they are they know that they have a low egg reserve for whatever reason, they must have tested and they know that their egg reserve is on the lower side, or they are having irregular periods, having polycystic ovaries, they may not get periods until and unless they take medication, or they have any tubal problems like ectopic pregnancy, and then previously and they have removed the tubes, or in males they have problem in having intercourse, or they have a low sperm count. For these type of people need not wait for 1 whole year to go and meet the fertility specialist. They need, or the woman's age is more than 35 or 40 there, they need to go and see as early as possible, at least by 6 months of trying. If they are not able to conceive, it's better to go and see the fertility specialist. How do we manage these couples for both men and women? First thing is basic history, examination, and few blood tests or scans investigation need to be done. History. For a woman, what history do we take? Why do we take? Certain good history taking can give us the diagnosis. We can know where the problem lies. First thing we want to know is how are her periods, whether she's getting regular periods. We assume that if a woman is getting regular periods, she should be ovulating. Whether she has irregular periods, whether she needs to take medication only, that she may not be ovulating. We may suspect that she may be having polycystic ovaries. Then another thing is whether they're able to have intercourse properly, whether there is any pain during intercourse. We may suspect endometriosis in that. These and their obstetric history, previous pregnancies, whether they have had any pregnancies, ectopic. These are the brief thing we need to do. Examination. Basic examination starts with the height, weight, their BMI. Obesity also can have effect on the fertility. So we need to know what is their height and weight and BMI. Then coming to their breast examination for any nodules or discharge. If there's any discharge, the prolactin hormone can be high, and this can have effect on the ovulation, development of the egg and ovulation, as well as pregnancy. So we need to examine the breast. And pelvic examination. Pelvic examination, some of the couple may not come and tell us whether they are having regular intercourse. So when we go to do a physical examination, that is pelvic examination, we may feel that they may not be having intercourse at all. It may be a non-consummated marriage itself, but they may have inhibitions to tell. So that when we take a history and examination, we can find out just counseling and helping them to have proper intercourse can help them get pregnant. So it's very important to take a good history and a physical examination. Then coming to the investigation. When do we do? What do we do? Minimum examination, minimum investigation, one is the scan, baseline scan. On the second or third day of the period to see for the uterus, how is it? Whether it is looking normal, no fibroids, no suspicion of any septum. And what is the egg reserve during that time? Normally, the tubes are not visible on 2D scan. If there is any problem and the tube is swollen with the fluid, then what we call it as hydrosalpinx, it may be visible on the scan. Then coming to certain hormone evaluation, hormone test, blood test, that is to know if we feel on scan the egg reserve is less, we do certain hormone tests, thyroid, prolactin. These are the few blood tests we do. Then the tubes, because basically the egg and the sperm meets in the tube. So uterus, ovary, and tube are the three things we test for in a woman. So that it is the tubes are tested, hysterosalpingography, which is done in the first half of the period. Coming to the man history again, whether his BMI, then history, that is smoking, alcohol history, whether they're able to have intercourse. These are a few things which we need to take. And examination. Usually, examination is kept for the last because we do the semen analysis. If semen analysis is normal and if they have no problem in intercourse, we don't have to do a physical examination of a man. In case the semen parameter is not normal or he is having any problem in intercourse, then we need to do a physical examination by an andrologist to see what is the size of the testes, whether there is any evidence of hydrocele or varicocele, we need to see. Then what investigation, as I already told, first we do the semen analysis depending on his history. Few hormone tests like TSH, prolactin and testosterone need to be done. And if required on examination, we feel there is any varicocele, then we need to do a scrotal ultrasound to see for the grade of the varicocele. Then are infertility issues treatable in both men and women? Yes, they are treatable, but it depends on the cause. What is the cause? Coming to the women, that is ovary. If we go ovary, tube, and uterus, what is the problem? In ovary, if they have polycystic ovaries, medical management needs to be done. If there is any insulin resistance, needs to be done. If it is endometriosis, depending on the size on ultrasound, whether medical management or surgical management will be required. In the uterus, if there is septum or a polyp, it needs to be removed surgically before they try for pregnancy, which will help them to conceive. Then if there is hormone imbalance, that is the thyroid or prolactin is up and down, give medication, medical management will rectify it. If there is any infection, evidence of infection needs to be treated. If there is any evidence of tuberculosis, and if required, surgery also may be required and anti-tubercular treatment will be required. Post that, they can try for pregnancy. And in men, for both, whether it's men or women, basic thing is lifestyle management. Lifestyle modification is very, very important. Diet, exercise, and reduce the weight, stop smoking, and stop alcohol intake. And if there is hormone imbalance in them also, needs to be rectified. And if there is any change in the count or motility, minimal change, antioxidants or any other medicine, hormone may be required for the rectification. And then coming to what are the basic treatment options for this infertile couple? That again depends on the cause. If it is just normal, everything is normal looking, that is what I told, unexplained. For them, or if the couple are unaware of their ovulation, getting regular periods, for them, we can do it, just monitor the normal cycle and ask them to have intercourse when it is right time, when we feel the egg is going to ovulate. And if it is everything is fine but not getting pregnant, we can do ovulation induction and ask them to have intercourse at the right time. Third thing is, if ovulation induction has and timed intercourse has failed, you can step up your treatment to ovulation induction and IUI, where the man gives his semen sample. We in the andrology lab process it, and the best sperm, quality sperm, are selected or taken out, and bypass the vagina, cervix, and put it directly into the uterus. So the chances are, that is at ovulation, that chances of pregnancy is increased. Now coming to the advanced treatment, that is the main topic of our this session. That is, we discuss on IVF. What are the advanced treatment options for infertility? Once when all these small treatment are have failed, then advanced treatment, that is IVF, in vitro fertilization, that is the fertilization of the egg and the sperm takes place outside the body. What is ICSI? Intracytoplasmic sperm injection. In this, it is same as IVF, where the egg and the sperm will be fertilized outside. In IVF, the nature selects one egg is incubated or kept in the incubator with the few sperm, and the nature selects or nature lets the best sperm to penetrate or pierce the egg shell and get inside the egg and fertilize. Here in ICSI, the embryologist in the lab will select the one best looking sperm and inject the sperm directly under the microscope into the egg, and fertilization takes place after that, same as the IVF. IVM, in vitro maturation. In this in vitro maturation, we take out the premature or immature eggs. We may give very few injections or the medicine, and immature eggs are taken out, and they are matured for a couple of hours or 24 hours outside in the embryology lab in the incubator, and the remaining part of the fertilization is same as ICSI. That is, one sperm is injected directly into the egg, and they are grown. These embryos are grown for 3 to 5 days in the incubator, and 1 or 2 embryos will be transferred. Now, for a male, what is the advanced treatment for infertility? One is TSA, testicular sperm extraction or testicular sperm aspiration. This is done for men who do not have any sperm in their semen parameters, or they have a very high DNA fragmentation index, DFI. For these people, we want to take it from the source. That is, the sperm production happens in the testis. So if we take it from the source, at the source, the fragmentation index will be less. So for that, we can take the sperm from there. PSA, that is percutaneous epididymal sperm extraction, aspiration, that is from the sperm, another part of the sperm, we take it. For these, when they have a block, they do not have any sperm in the semen parameter, but they are producing adequate number. For these, we can aspirate from the or extract from the epididymis and do the ICSI procedure. For some people, there may be very few sperm production in the testis, so we need to search and take it out from the testis. For them, we do it under microscopic guidance. Under the microscope, we see where the probable production is happening, and where we feel that production is happening, that part of the testis, small tissue is taken and given to the embryologist. The embryologist will tease out and take the sperm out from the tissue and use it for ICSI procedure. How do we do this IVF procedure? IVF procedure, usually it is done or started from the 2nd or 3rd day, but before that, baseline evaluation of the couple is done. 2nd or 3rd day for a woman, again she has a baseline scan to make sure that the everything is in the baseline. That is, endometrium is thin, everything, there are no cysts from the previous cycle, and we start off with the medication. Medication is in the form of injections. Sometimes a little bit of tablets also are added, and this medication is given for the woman to produce more number of eggs. Normal cycle or natural cycle, 1 or 2 eggs are produced, and this is not sufficient to do IVF or ICSI because it's a laborious procedure, and we need more number of eggs to produce more number of embryos so that she'll have a more chance to try for pregnancy. When we give this egg with injections, we expect them to produce at least 6 to 8, give us 6 to 8 mature eggs, but it is not necessary they're going to give us 6 to 8. It depends on our egg reserve. We may get 1 egg also, we may get 20, 25, 30, 40 eggs. That is in polycystic ovarian women. These eggs we give in medication for a minimum of 8 to 10 days, and when they are of the right size, that is 18 to 20 millimeter, she will have a final injection. These injections, initial 8 to 10 days, for the growth of the follicle is given, and the final injection is for the maturation of the eggs inside these follicles. is given, and 34 to 36 hours from that final injection, the eggs are retrieved or taken out under ultrasound guidance and under anesthesia. There will be no cut or no stitch. Under ultrasound guidance, a fine needle is introduced and it is aspirated. That is, the follicle is aspirated. Follicle contains the fluid. In this fluid will be the egg. This fluid will be handed over to the embryologist. The embryologist will scan the fluid under the microscope and pick up the egg, identify it and pick up the egg. These eggs are kept in the incubator for 2 to 3 hours. Then with the fresh semen sample, if it is available. If it is not available, frozen sample will be used. And the embryologist will inject one sperm into one egg directly seeing under the microscope if it is going to be the ICSI procedure. If it is going to be an IVF procedure, one egg with few sperm will be incubated in the incubator for a couple of hours, and the following day they will check for fertilization. In the fertilization, they will come to know out of that many eggs how many have fertilized, and they will grow it further for 3 to 5 days depending on various factors. And it will be a fresh transfer or a frozen transfer. If it's going to be a fresh transfer, one or two embryos will be transferred back into the uterus between third to fifth day from the egg pickup, depending on various factors. The fresh transfer or the frozen transfer will be decided. The remaining good quality embryos will be frozen, which can be utilized for a second baby if they get pregnant in this cycle. If there is no pregnancy, they can, if they have a good quality embryos frozen, they can just prepare the lining and go for frozen cycle and have the transfer. And the success depends on many factors. And when do we do this IVF and ICSI cycle? IVF ICSI cycle are done for both male factor and for female factor. And when all the small treatment, what I told, timed intercourse and IUI have failed, then we go for IVF or ICSI treatment. And in the female, especially in female, if there is advanced age and her egg reserve has come down, when the reserve comes down, quality also comes down. So we do not want to waste time asking her to go for small treatment. We may advise her, depending on case, advise her IVF ICSI. Or if the egg reserve is very low, she may not be, it may be very low, she may be producing very few eggs. So we want to get the best eggs. So we may go in for IVF ICSI. Or if the tubes are blocked for whatever reason, removed or blocked, then also because the gametes, the sperm and the egg cannot meet for that time, we do IVF ICSI. And in men, if they have very low sperm count, they may be having very, very minimum to achieve a normal pregnancy or to go for IVI. This may not be a good result for those kind of men. We advise them to go for IVF ICSI. And there are men who do not have sperm at all in the semen parameter when we do the semen analysis. Even these men can father their own biological child. For them, we need to take it directly from the testis. So just because the semen does not have any sperm doesn't mean they have to go for donor. If they are interested in having their own biological child, then they need to go a certain evaluation, that is examination and ultrasound. That if we have that, there is chance chromosomal analysis also should be done, so that counseling can be done for the couple whether they can go ahead with their own sperm and try for biological child, and directly we can take it from the testis if it is available and go for ICSI and father their own child. So these are the people whom we say they can go for IVF ICSI. Next question is, are all IVF ICSI cycles successful? No, not all IVF ICSI cycles will be successful. The success will depend on many factors, both male, female factors. What is the cause for infertility is the main cause. But there may be very few egg, that when the egg comes down, as I told, number comes down, quality also comes down. The sperm may be also not of a good quality. The morphology we see for not only the count and motility, even morphology, which can have effect on the gamete formation or the embryo formation, age of the patient, and the quality of the egg and the sperm and the embryo. How many cycles of IVF can be tried? that depends on the patient or the couple, how many cycles they want to go undergo, because it is cost is one of the factor, and what is the cause also will be another factor. If there is any obvious cause, means to say that she may not be producing eggs, or we may get one egg which is of a bad quality, there is no meaning in going in for 3 4 cycles and getting one egg which may be of a poor quality and which may not fertilize at all. So the cause also, what is the cause also will matter. Financial factor also should be taken. So depending on all that, the couple have to decide how many cycles they want to go. But of course, they cannot go for it. It's not advisable or wise to go for uh, n number of cycles, just knowing the cause and trying again and again the same treatment. It's better to go for better option or the options which have a better success rate for them. And what are the complications? Like any other thing, any treatment has its own complication. What are the complications associated with the IVF excessive treatment? We want to avoid the complications associated with the treatment. So we do a very close monitoring. We do at least 4 to 5 scans. In that 8 to 10 days of injection time, scans will be done, blood tests will be done. Where we feel she may be producing too many eggs, that time we we alter the dose of the medication so that we are not pushing her to produce too many eggs and develop OHSS, that is ovarian hyperstimulation syndrome. And since we transfer two embryos sometimes, that can become triplets or quadruplets. Even single embryo can split on its own and give rise to twins. And these high order multiple pregnancy triplets, quadruplets have their own complication. Even twins for that matter. Triplets and quadruplets can go in for miscarriages, preterm deliveries they can have, and multiple pregnancies can have high blood pressure during pregnancy, diabetes development, preterm delivery, babies going in for NICU, preterm, uh, severe preterm deliveries is one of the cause. Another one is ectopic pregnancy. Ectopic pregnancy, we only can go and put the embryos into the uterus, but the uterus can sense that there's something foreign body. So as soon as we put the embryo, will not go and stick in the endometrium. It keeps moving around in the uterus for some time, or 1 or 2 days, depending on which day transfer it is, and then only it sticks. In that process, when the uterus is trying to contract and put out the embryo can get into the tube and start growing in the tube. The tube can help or support the pregnancy for about 5 to 6 weeks. That's all. It bulges out and it can rupture, and the woman can have bleeding, which is called as ectopic pregnancy, and it has its own complications associated with that. Many, depending on the size, medical management and surgical management may be required. And when we are giving injections, the medication itself can have some local reactions like itching, swelling can be there. Depending on the what is the reaction, we may have to change the medication. Now, after finishing this main IVF, I would like to stress on one topic, that is the fertility preservation. When do we do? For whom is it advised? What is fertility preservation? This cancer patients, when they before they go in for chemotherapy or radiotherapy, fertility preservation is an option given to them. Most of these chemotherapy drugs can have effect on the egg production or the sperm production it can have, and some of them can permanently destroy. For some, after 2 or 3 years the production can start. For these type of patients, we offer fertility preservation, where before starting their chemotherapy or radiotherapy, they go for IVF, and if they are married, they can make embryos, preserve those embryos, finish all the treatment after 2 or 3 years when they are for oncologists say that she is in good health and she can try for pregnancy. They can come back and have these embryos transferred and go for pregnancy. Or if the woman is still not married, she doesn't have a male partner, she can freeze, she can make the eggs, means to say, she can undergo IVF, where we can do the egg become, give medicine which are safe for her during that cancer period, take out the eggs and freeze those eggs. Later, when she gets, after treatment of the cancer, when she decides to get married and have babies, we can use the sperm of her male partner, make embryos and transfer. It's not only for the cancer patients, It's also for other problems like endometriosis. Endometriosis is a recurring problem. You cannot treat. Treatment is only to stop the pregnancy, stop the periods. We cannot stop the period indefinitely by medication, because medications have their own implications on the body, on the bone. It can have effect. So for these people who are having recurrent endometriosis and they need to go for recurrent surgery, for these people we advise fertility preservation for them as well. They can, if they're married, make embryos, and if they're not planning to have babies, they're career oriented or for whatever reason, studies or something, they don't want to have babies, if they have a male partner, make embryos and keep and suppress the endometriosis. If they are not married or they do not have a male partner, they can go for IVF, make these, do the egg pickup and freeze those eggs later to be used when they are planning for pregnancy, to use those eggs with, to make embryos with their male partner. Another very upcoming thing and everybody is speaking of is the social egg freezing. Women now are want to pursue their education, career, and they are postponing their pregnancies for late 30s and early 40s, when it is when it may be late, or they have exhausted all their good quality eggs, and they may not have a very poor, or they may have a very poor egg reserve, and the quality may be poor, and they may not be able to have biological child of their own. So for such women, we have social egg, what is called as social egg freezing, where they freeze their eggs when they are young. The thing is, better to go for, if you are not planning for pregnancy before late 30s or early 40s, better to freeze those eggs at an early age when they are less than 35 years, so that you get good number, good quality egg which can be used. If you get pregnant later on your own, there is no need for these eggs, because what you're frozen. But if there is any problem, so for those in such situation, you can use these eggs which are frozen and go ahead with pregnancy. But one thing I want to caution the women who are planning to postpone their pregnancy is, before you decide on postponing your pregnancy for a later date, even if you are less than 35, better to meet your gynecologist. Meet a gynecologist, get yourself assessed. A basic scan and one hormone test will tell whether your egg reserve is adequate. Then you can plan for your postponing your pregnancy. If it is indicating that your egg reserve is on the lower side, please do not plan for postponing your pregnancy. If you still plan to postpone your pregnancy, do your embryo freezing, that is, do embryos if you're married, go undergo IVF, freeze those embryos to be transferred later. If you're not married and you're not planning to get married or not planning to have babies soon, and you're still less than 30, if you are seeing women less than 30 years having very low reserve, we do not know what is the reason. Maybe due to all the pollution, adulteration, plastic, all these may have had implication when we were still in our mother's womb. That may be showing up now. Do not know. Everything is still under studies. Some are showing that all these may be having implication. So women, if you are not planning to have pregnancy now, better to get yourself evaluated once by your gynecologist, if not reproductive medicine specialist. Make sure that you have a good reserve by scan and one hormone test, and then you can plan for postponing your pregnancy or family. Next, what is the take home message from this talk? One is, fertility issue is on the rise, so that needs to be cautioned. You have to have a good what to say, lifestyle. Lifestyle modification is a very important thing. Not to postpone pregnancy till late 30s or 40s, early 40s. Lifestyle modification, weight reduction, diet, exercise, stop smoking, alcohol, important. To see the fertility specialist if there is no pregnancy in 1 year of unprotected intercourse, or early if there is a known cause for getting delay in the pregnancy. Fertility evaluation before postponing pregnancy for social reasons. Even if a woman is less than 30 years, it is advisable to get yourself evaluated before you postpone pregnancy. Thank you. Any questions? Feel free to ask. Hope you have got good advice regarding the fertility preservation, then social egg freezing, and the basic information regarding the IVF procedure itself. Questions? Anybody having question? Feel free to post them. Is unexplained infertility really unexplained? Since we see only the gross, as I told you, uterus, how is the uterus looking? Is it looking normal? Is there adequate reserve in the ovary? Adequate number of eggs are seen on the scan and hormone wise. And semen parameters are within normal. Like tube is open. These are the few things what we see. In these, grossly, if it is normal, then we brand or declare it as unexplained infertility, which is not a pleasant diagnosis for the patient or for the doctor, because there is no reason. They may be the problems may be at the microscopic level. To do the microscopic, see for the microscopic problems, we need to do IVF. In that, we take out the egg. We will know whether there is an egg. We only see whether the follicle is developing. We do not know whether there is an egg really in that follicle. Only when we do IVF, we take out that follicle, then we know whether there is an egg, what is the quality of the egg. When we inject directly also one sperm into the egg, whether that fertilizing, what is the quality of the embryo. These all can be answered only when we do IVF. So, grossly what we are saying, we see and we say it is unexplained. But the problems can be at the microscopic level, immunological level, problems which we are not testing at the first go. So, we say it is unexplained. Why am I not getting pregnant when everything is normal? That's what I was telling. Everything may be looking grossly normal, and then you may not be getting pregnant. When small things, when smaller treatment don't give you pregnancy, you will go for higher treatment. That is when we come to know whether there is any problems at the microscopic level. So the problem may be at the microscopic level, immunological level. These things may be the cause for your problem in getting pregnant. How many rounds of IVF does it usually take? There is no hard and fast rule that you have to have 2 or 3 IVF. There are many people who get pregnant in the first cycle itself. There are some, they have done one cycle of IVF and they still have embryos, they go in for transfer, repeat transfer, they get it. So there is no hard and fast rule you will get pregnant in this number of cycle. You have to undergo, to get a positive pregnancy, you have to undergo 2 or 3 or 5 or 1 cycle. It's not, there's no hard and fast rule. So it all depends on the gametes, that is the quality of the egg, quality of the sperm, and the quality of the embryo. That is 70% comes from the embryo, the cause. I mean, good embryo should be there. Another 25 to 30% is contributed from the endometrium. The endometrium also should be ready to accept that embryo and let it grow there, nurture it. So there is part played by the uterus, that is the endometrium, plus the embryo. So both of them need to be in good condition and in right, what to say, hormone synchrony to get a pregnancy. Are there any pros and cons of IVF? I already said what are the complications associated with IVF. Um, Problems can like OHSS, then ectopic pregnancy, multiple pregnancy, and the reaction due to drugs itself. And coming to some of them have a myth that cancer can be developed. Usually, we do cancer IVF in cancer patients also. So we cannot say the IVF itself is giving rise to cancer. There is some genetic problem. That is the reason why we take time to take history from the patient to know if there are any a family history of cancers, and are they genetically prone for cancer? So all this will help us to choose the drugs and do the IVF. And coming to, some of them may have a doubt whether these babies born from IVF are abnormal or are they same as normal preconception babies. Studies have shown that natural pregnancy, there can be some problems, developmental problems in about 3% of the babies. And in the studies have shown that IVF also about 4% or maximum 5%. So there is no statistical difference between the natural pregnancy and the IVF conception babies in the structural abnormalities, significant, statistically significant, what to say, abnormalities. Any other questions? Thank you.